Did I do it? Oh yeah. Okay.
Yep.
As always, so this week's proximal humerus fractures, we're going to start off with a review of last week. So that was distal radius fractures. That was given by Aaron Rubenstein, one of our PGY5s, who's doing hand fellowship at Allegheny General in Pittsburgh next year. We have poll questions for you guys. So the first one is, let me pull this up. So how do you obtain the best view of the distal radius joint? This is, how do you see the joint line best? And this is to assess for your reduction of the joint. And you can also tell if you put any screws in the joint line. Hey, Joe Galloway, welcome. So another one of our PGY4s, Joe Galloway, just joined us. He's interested in trauma, like myself. All right, just gonna give you guys a couple more seconds to pull on in on this. Alrighty. Hey, Akil, are you on? But did you have?
Yeah, I'm here.
All right.
You
So
hear me?
I'm gonna call you out on this one. So
All right.
What do you think?
The best view would be to get a tilted lateral view.
Yeah. So do you remember why?
The main reason is that styloid process of the radius. It's on the most lateral part of your radius, and it extends more distally than the rest of your radius. So if you get a regular lateral view, then it can look like, if you put any screws or anything like that, it can look like some of the screws are going into the joint line. But the tilted lateral view would give you a better, more accurate image.
Yeah, nice job. So Akil is one of our rotating or home students, and we had a distal radius fracture that we did today. So that's why I kind of just felt like pimping up a little bit. But yeah, so due to the shape of the distal radius, you'll see on a couple slides from now how it's shaped, but by tilting it, and it's in this image, it's saying 10 degrees. It's anywhere from 10 to 25-ish degrees, depending on the patient's anatomy. But by tilting it up, you're going to have the projection of the the X-ray beam go down the joint, and you'll be able to see the joint line much better. So, next question is, what is acceptable criteria for a non-operative treatment of a distal radius fracture? And so there's usually four main things that we look at when we're assessing. This is after we do a reduction of the radius fracture and we put in a splint, then we're going to assess on our post-reduction radiographs and see. So this is a little bit of a tricky question because it's a little bit more advanced, but just go through it and think of what kind of stands out the most. All right, right now we're at a tie, so I'm going to wait for one more person. All right, there we go. Nice. So yeah, the majority of you guys got this right. So 3 millimeters of shortening was the answer for non-operative treatment. And so we usually look at, like I said, four main things. radial height, radial inclination, volar tilt, and any articular step off. So easy way to remember this is you just pick one of them, the volar tilt or radial height, and it's 11. And then the radial inclination is twice that at 22. And then anytime we're worrying about articular surfaces, usually the answer is 2 millimeters. All right, and then question number 3. So the majority of the time for distal radius fractures, we're doing a volar approach, and we do this through the FCR approach. And so what are things you have to protect during this approach? I think we touched on it briefly last time. Keel, you should know the answer, but I'm not going to call you out again. Alrighty. So again, you guys did a nice job. And so the answer is both A and B. And so you pretty much for this approach, you make your incision over the FCR tendon, and then you go through the tendon sheath, and then you come down onto the FPL muscle belly and you retract that over. But while you're going through this interval, you have to pay attention and protect the radial artery, which is going to be on the radial side. And then more ulnarly is going to be your median nerve. You don't see it, but you should be protecting it with your retractor, and also you have more of your flexor tendons in this area that you're retracting out of the way. And then you come down onto this structure here, which is the pronator quadratus, and oftentimes it's ruptured and torn due to the fracture. And if it's not, you have to just take it down anyway. So you incise it on the radial side and also the most distal aspect of it, and kind of you make a kind of half of a square or a little corner and you peel that away, and then that allows you access to see your fracture. So like I said, it was A and B because you have to protect those two main neurovascular structures. All right, and then the last, everybody's favorite question, the bonus question. So let's see what we got here. Do you guys prefer dogs or cats? Camille, what's your answer?
Dogs.
Dogs. Joe?
Joe Galloway?
Hey, Becca, what about you? All righty. So I prefer dogs as well, so I'm with the majority here. Joe, we can't hear you. I know you tried talking, but. All righty. All right, so on to the main part of the lecture here. Let me stop sharing. And Camille, you can get on in.
So I'll share screen. Desktop 1, sure. Jeez. Will not be able to record the content until I quit. Okay.
What's up? So, Camille, you got it? There we go. Can't hear you though.
Can you guys hear me?
Yep. Can hear you, can see your screen.
Okay. Okay, welcome everybody. Today's topic, we're going to be going over proximal humerus fractures. Did you guys usually make this interactive or just kind of questions at the end? Jeremy? Joe, can you hear me? Okay. You guys can stop me if you guys have any questions. So let's see. Okay, so a quick outline for the presentation. We'll first start off with a case presentation. We'll talk about the epidemiology of proximal humerus fractures. Talk about important biology in terms of the vasculature and other important aspects that can help dictate operative versus non-operative treatment. We'll talk about some of the classification systems that we use to describe proximal humerus fractures. We'll describe some of the important imaging and specific views that we look for and how we assess these images. And then finally, we'll just touch briefly on some of the main different types of treatment options available depending on the severity of the fracture, if it even needs surgery at all. So for our case, we have a 54-year-old right-hand dominant woman. She's an avid tennis player, so that just tells us she's active. She fell onto her dominant shoulder during a tennis match. These are the x-rays that we first got, so I'll discuss those very shortly. So for our physical exam, just want to also highlight, these are like the main things when we're doing a physical exam from an orthopedic standpoint of an extremity. We look for, you can kind of use this as a gauge to kind of evaluate the 5 things we look for. So for inspection, we're looking at skin. So the skin was intact. There was some ecchymosis and swelling. There was some bruising over the right shoulder. When we did palpation, she was only tentative palpation over the shoulder. There was some crepitus felt over the right shoulder. When we talk about neurological testing, so she was 5 out of 5 strength distally. So we can, that's including her elbow flexors, extensors, wrist flexors, extensors, finger flexors, extensors, and so forth. Sensation was intact in all distributions distally as well. Vasculature, she had a palpable radial pulse. For her musculoskeletal exam, she had limited range of motion at the shoulder due to pain. Otherwise, she had full range of motion for all her other joints distally. When we looked at her available imaging, so we see a right proximal humerus fracture. The first view, it looks like it's an AP or a Grashy view, but we see that the greater tuberosity, which I'm highlighting here, seems to be displaced. There's also another fracture line that goes right here. And there might be a fracture line as well here on the lesser. When we look at, this is the axillary view. I'll show you how to obtain those views shortly. Again, this view is important. One, it tells us that the shoulder is not dislocated, and you can also appreciate other aspects of the fracture. And you can also see other lesions, like Hill-Sachs lesions on the humerus, which we won't really touch on in this presentation, but these are just important views to know. Finally, for this patient, they obtained a CAT scan. This is just one cut that was available. And the nice thing is they measured for us 1.2 centimeters of displacement. And this will come in, become important later when we dictate management. So what is our best treatment option for this young, active female who has a right proximal humerus fracture with displacement of the greater tuberosity? So in general, proximal humerus fractures are very common. They're they're the 3rd most common elderly fracture that's not excluding the vertebral fractures. They can also be bimodal, so they can also occur in young patients due to high energy mechanisms. There's several complicating factors that can dictate treatment of these, and these include poor bone quality, especially as we mentioned, this happens in the elderly, so sometimes there's a lot of osteoporotic bone, and the need to have early motion to avoid stiffness of the joint. So sometimes with these fractures, it's very difficult to obtain a good reduction. And then if you do obtain a good reduction, to maintain that reduction. And then finally, whether fixing it or not fixing it, to get a good functional outcome. This diagram here on the right shows a lot of the x-ray with all of the parts of the shoulder labeled. So just briefly, we have the greater tuberosity here. We have the lesser here. The bicipital groove will run between them. The surgical neck is outlined here. And then the anatomical neck is outlined on the more proximal aspect here. So these are important. I'll show you why when we get to the classification system. So risk factors for proximal radius humerus fractures. As we mentioned, it's for a lot of times it happens in the elderly. So osteoporosis is a big one. Diabetes. Females are twice as likely to get it than males, and epilepsy. So moving on to the epidemiology. So it occurs approximately, the numbers change, but approximately 5 to 6% of all adult fractures. As I mentioned earlier, the majority happen in the elderly. There is, because it happens in the elderly, studies have shown that there is an age-specific incidence increasing in patients. As I mentioned briefly, there's a 2-to-1 ratio of females to males. 51% of the time they're displaced, and 77% of the time it involves the surgical neck. So it's the third most common non-vertebral fracture seen in the elderly. The top two are hip fractures and distal radius fractures. And patients older than 65, it accounts for 10% of all these fractures. And there's differences in the studies, but 50 to 80% of these are minimally displaced and require no operative treatment at all. So a lot of the times they're treated without surgery. So the vascularity is very crucial to understanding these fractures and what sometimes dictates management. The anterior humeral circumflex artery, which is shown here, is thought to provide the majority of the blood supply. There's also the arcuate artery here along the lateral aspect of the groove. There's a study done in the 90s, and this just kind of shows you the area that's not shaded in gray is what's provided by the lateral ascending branch of the anterior humeral circumflex artery. Again, this just shows both the anterior circumflex and the posterior circumflex arteries as well, because up until recently, it was thought that the anterior circumflex provided the most blood supply. However, recent studies and clinical findings showed that even when there was injury to the anterior lateral circumflex artery, the head remained perfused. So some studies have now shown that maybe it's the posterior circumflex vessel that may be contributing more than we initially thought. There is, this becomes important when we think about fractures that disrupt the blood supply, and when we think about humeral head ischemia. So there is a criteria called Hurdle's criteria, which identifies specific factors and it incorporates how the fracture patterns look like. So the vascularity of the articular segment is more likely to be preserved if there's greater than 8 millimeters of the calcaries attached to the articular segment. Some predictors that have been shown, these are the Hurdle criteria for humeral head ischemia, are if you have less than 8 millimeters of calcar length attached to the articular segment, a disrupted medial hinge, increased fracture complexity, displacement greater than 1 centimeter, and or angulation greater than 45 degrees. So this was just showing you guys the integrity of the medial hinge. On this side here, there is almost no, it's less than 8 millimeters. And on the right side, there is greater than 8 millimeters. And this study shown here, it was 99%, 97% positive predictive value of having ischemia in the humeral head. This just shows it with an X-ray. So if you have extension, the medial aspect is less than 8 millimeters, this potentially can cause ischemia. So in this example here, there's less than 8 millimeters. So just by looking at the fracture pattern and knowing Hurdle's criteria, you could guess that this head is likely not viable because the blood supply has been disrupted. We can kind of touch on this already. This is an important slide, and it kind of, it's always important in any fracture because knowing where the muscles attach can help dictate the displacement of fracture patterns. So here we see all the muscle groups that are attached to the proximal humerus. So if you guys can see my pointer, this muscle here is the pec major, and it's going to displace this shaft anteriorly and medially when it contracts. The supraspinatus, so the rotator cuff muscles, so the supraspinatus, the infraspinatus, and the teres minor, which attach to the greater tuberosity. If there's a fracture of the greater tuberosity, these muscles will contract, and then based on what their function, they're going to abduct and externally rotate the greater tuberosity piece. The subscap, which attaches to the lesser tuberosity, is going to internally rotate the lesser tuberosity. And if it's still attached to the head, then it'll internally rotate the head. This is showing when all of these fragments are completely separated from each other. So it'll show all the muscles acting on each respective fragment.
Camille, can I just interrupt for a second? I think that this slide, I can't overemphasize how important it is. I think it's something that's easily pimped, and for a medical student to know their anatomy. And then two, for a higher level to treat this, you need to know what type of forces you need to counteract. So this slide, I think, is something that needs to be really understand, and something that you guys should really focus on and review because it's really important.
And these types of slides that show the muscles are important, not just in the shoulder. A lot of times, like as Jeremy mentioned, like these easily pimped questions, same thing will happen in proximal femur fractures, intertroch fractures. Understanding where the muscles attach can help you dictate where that fragment is and what's causing the forces on that fragment. Okay. So we mentioned bone quality earlier. As we mentioned in the beginning, this fracture usually happens in patients who are elderly, who have poor bone. So this was a study that kind of determined the mean cortical thickness and identified the bone quality per se. And they came up with an equation, which we don't have to memorize. It just kind of shows, it's kind of intuitive. The thicker the cortex is, the better the bone. So in this case, having they counted less than 4 millimeters of thickness was indicative of low bone mineral density, or that's higher chance of having a osteoporotic fracture. So the classification system for proximal humerus fractures is probably one of the more, I would say, annoying classification systems. It's not as easily, it's easy to understand, but there's significant variations to it. And there's several different classifications, which can explain to you guys that not one is the best. One of the main ones that is usually used and described is the Neer classification, which describes proximal humerus fractures based on parts. And there are 4 main parts, and we kind of alluded to them earlier. It includes the greater tuberosity here, the lesser tuberosity, the articular head or the segment, and the shaft. Depending on displacement and angulation, that's what will define a part. So, and based on Neer's classification, it has to be greater than 1 centimeter of displacement or 45 degrees of angulation. There was a modification later that for the greater tuberosity, instead of having 1 centimeter, it's half a centimeter or 5 millimeters. And we'll discuss why that piece specifically is the most important. So again, here, we mentioned here again, the 4 parts. And we mentioned earlier with the muscle diagram what muscles attach to each of these parts. So you can also understand, you can try to visualize in your mind where these fragments will be. And especially when you're looking at imaging, to understand what's causing them to be displaced in that direction. In addition to the NEAR classification, there's also the AO classification, which describes all the it's used to describe all the bones in our body. So in the utility of the AO classification here, it classifies them basically into three main categories, and it bases everything on the surgical neck, the presence or absence of a dislocation. But with this classification, it's difficult to predict the level of AVN. This is just another diagram that shows the three different main parts here. The reason I'm showing you this, you don't have to memorize any of this. The reason I'm just showing you this now is there was an algorithm created that basically used this AO-OTA classification to determine how much, which fractures would need surgery and which fractures would need fixation and what type of fixation, which I'll show you guys that at the end. So when we, for every fracture pattern, for every fracture, there's specific views that we'd like to see. So in general, for when you have proximal humerus fractures, if you want to see the entire fracture and try to understand the morphology and try to get as a complete picture as possible, you can start by getting just a regular AP first. And then you can get something called a true AP or a Grashy view. And this is just this diagram here, the illustration on the right, just shows you how you would get it. Kind of have to internally rotate the beam so you can better appreciate the glenohumeral joint. There's also a transscapular Y, the transscapular Y view here. And sometimes you can use this to see if there's any dislocation, but we have a better view for that, which I'll show you guys shortly. This is a really important view, and I mentioned this earlier. This view can show us, one, if the more detail on the fracture pattern, but it can also show us if the joint, the glenohumeral joint, is dislocated or not, because that would change management. If you have a proximal humerus fracture dislocation, that's going to be much different than just having a proximal humerus fracture. And the illustration on the top right is how these views are usually obtained. I didn't include it in my presentation, but a lot of times you can imagine if you have a proximal humerus fracture, it's going to be very difficult to have the patient in this extend their arm and abduct their arm like this. So there is an alternative to this called the Velpo view, where I can show you guys at the end after the PowerPoint is done of how you can get a similar view to the axillary without having to actually position the patient like this, especially if they have a fracture and they're unable to move their arm due to pain. Depending on the fracture morphology, or if you need to see more detail of the fracture, if you want to see if there's a head splitting injury, how much displacement there is, if there's a Hill-Sachs lesion, you can also obtain a CAT scan, which will show us better bony detail. It'll give us a more three-dimensional view of the injury when you're looking at all your different cuts, your axils, your coronals, your sagittals.
Weekly Skype call, there's no
So once you have your x-rays done, once you have your physical exam, once you know the comorbidities of the patient, if they're a healthy patient, if they're a compliant patient, what their goals were, how functional the patient was before the injury, and then you could start looking at your imaging and assess your fracture, understand where the fragments are, understand where the displacement is. So again, you look where the greater tuberosity is, where the lesser tuberosity is, where the head fragment is, where the shaft is, how much shortening there is, if it's dislocated or not. And then, so this is just highlighting the greater, the lesser, and then that's where the fracture is through the neck. So as I mentioned earlier, the majority of these fractures are stable and can be treated non-operatively. We put them in a cuff and collar and just have serial follow-ups to make sure that the fracture is healing and the patient's pain is controlled, and they're ranging their elbows and the rest of their extremity to prevent any stiffness. So some studies have shown that yes.
Sorry to interrupt you. Why is the cuff and collar better than, I've heard a lot of people put these in slings?
Right. So you'll see a lot of these for if you can imagine, when you have a sling on, your elbow is protected. Your elbow is not allowed to hang down. It's kind of being stopped by the sling. So with these, you want gravity to kind of push that down a lot of times, especially if there's displacement of the shaft superiorly into the articular segment or into the head. Gravity can help with these. So if you have a cuff and collar, you can imagine you have the cuff on your wrist. It goes around the neck. The elbow is hanging freely. So gravity is actually helping you push essentially your elbow and your arm down. Whereas if you have the sling, you can't really hang your arm at all because it's stopped by the sling itself. And we can show that with illustration with the pen at the end. That will so a lot of times when you guys see these and they go to the ED or they go to a place where an orthopedic doctor didn't treat these, they'll put them incorrectly in a sling, and when they follow up, a lot of times when they come to our hospital for follow-up or anything, we'll transition them into the appropriate immobilization device. So the treatment principles for these, you want to maximize the function. You want a stable fixation if the fracture is deemed unstable. You want early rehab, especially for the joint. You want to be able to, you want the patient not to develop any stiffness, and you want to minimize their pain. So it's important for these fractures, especially when we talked about they happen in the elderly. One of the most important questions we always like to ask is how functional was the patient before the fracture? If the patient was elderly, if they were sick, especially if there was like any sign of dementia and they weren't really functional, and they have a fracture, there's no point in kind of being super aggressive on that patient if they weren't using that extremity, or if they were if they didn't have that much function in the extremity before the fracture. There's no point in putting them in unnecessary risk of surgery, because every surgery has risks if there's going to be no improvement in their life or their function. So that's one thing to always keep in mind, not just for these fractures, for a lot of fractures in the elderly. And then once you understand the patient, the clinical aspects, look at the actual fracture, and you can think about the fracture fragment sizes, how much displacement. We touched briefly on the bone quality to assess how osteoporotic is the patient, and that might play a role in see what type of fixation you want. And then if there's a varus and valgus deformity and the importance about fixing those to improve your shoulder mechanics at the end. So there's a lot of indications. Sometimes they keep changing. Sometimes the thresholds change based on different articles. But in general, the indications to fix these are, in addition to the more commonly applied indications to everything, such as if it's an open fracture or if it's a dislocation, but assuming that the fracture is closed and not dislocated, significant displacement, especially of the greater tuberosity, angulation greater than 45 degrees, having varus deformity, and any significant comminution, especially if the patient, and then age, of course, is we mentioned, having a 25-year-old who has a proximal humerus fracture from a high energy trauma, as opposed to a 90-year-old with a fall. Those two, you're going to treat them completely differently just based on how functional the patient is. So other questions to consider are, is the fracture likely to displace with activity? Is the fracture likely to heal in its current position? If it heals in this current position, is it likely to impair function? And can the patient do physical therapy and benefit to get benefits from surgery or from non-op surgery? This was the diagram algorithm I alluded to earlier that kind of goes through each of the AO classifications, how much, what's the bone density in terms of are they very osteoporotic, or do they have good cortex to be able to tolerate fixation, and then how much displacement there is. And they kind of go through from just having a simple sling all the way to fixation with locking plates, to if it gets really bad and there's articular involvement and the articular surface is deemed non-viable, whether from the actual injury or from the vascularity, you can do a hemiarthroplasty, which will just change the humerus side. And then finally, I'll touch on this as I'm going with the PowerPoint, but just giving you a quick overview. There's more recent literature now that have been treating displaced 4-part fractures in the elderly with reverse total arthroplasties. So this is kind of the, in one of the review articles that kind of mentions each one. So in general, for in the elderly non-displaced, as we mentioned, 80% of the time they get non-operative treatment. This should say a cuff and collar, and we'll do a range of motion to help ensure that they're getting prevention of any stiffness in their joints. If there's significant displacement, if there's 66% of the surgical neck involved, greater than 5% of the greater tuberosity, then we will obviously have to do operative treatment. And then, as I mentioned before, one option is to go into the locking plate. We're not going to touch a lot on the different types of surgery, just a little bit more advanced. I just want to kind of show all the different options available for you guys. This is, I haven't seen this done as often, just having closed percutaneous pins. There's a lot of dangers in putting these pins in terms of migration, in terms of the important neurovascular structures around the shoulder. But this was one thing that the algorithm showed. Here, again, we mentioned these before with having ORIF, but most of the time now, these are treated with locking plates. If you have poor bone quality, there is significant displacement. In the elderly, one option is to do no surgery, or you can go on to and do a hemi, which this is an example of a hemi. This is an example of an X-ray that showed significant displacement. The head's completely turned off. This was a patient who was in their 90s. They ended up getting a hemiarthroplasty. These are the X-rays, and then this is just showing you a clinical picture of during the surgery. So this is essentially now the new head, and then the glenoid part remained the same. So hence the hemi, only half of the shoulder was changed. So the hemiarthroplasty is a good option, especially in the elderly. They provide pain relief. Their good function depends on anatomic tuberosity displacement. So we still need to repair the tuberosity in terms of the greater tuberosity and the lesser tuberosity. As we mentioned, all of the rotator cuff muscles for the shoulder attached to the two tuberosities. So the function depends on the anatomic placement of those tuberosities around the hemi. And even with anatomic placement of the tuberosity, studies have shown that the majority of patients still have difficulty achieving more than 90 degrees of flexion. And that's what we're showing here. As we get more and more poor bone and there's more involvement, hemi becomes an option. And finally, for large 4-part comminuted fractures in the elderly, the last salvage option is the reverse total shoulder. So that it's called the reverse because normally we would have the head on, like normally on the humeral side, and the glenoid would be the cup, but it's called the reverse because, as you guys can see in this picture here, the ball is now where the glenoid used to be, and the cup is on the humerus side, so it just reverses them. This is a last salvage option. A lot of more recent studies have started showing using this for patients who have complete fractures that are deemed inoperable in terms of fixation. And some of the outcomes have been promising. You do get a lot of limitations in surgery, but again, for the elderly, you're looking at more pain control and having them have a stable shoulder than more in terms of the functional aspect.
Hey Camille, what's different with a reverse?
Yeah, So if you have a normal shoulder, we assume that your rotator cuff muscles are working. But if you have for the reverse, it does not depend on your rotator cuff anymore. So if a patient has either an elderly patient has a history of a complete rotator cuff injury, or no rotator cuff, or torn, or the tuberosities are inoperable, they can go and because of extensive comminution or just poor bone stock. The reverse does not depend on the rotator cuff, unlike the hemi or a regular total shoulder arthroplasty.
Yeah, the deltoid is doing most of the motion because it's lateralizing the center of rotation due to flipping those components around.
We're not going to mention these in detail, but just some of the main surgical approaches that are used for fixing or replacing. You can do a deltoPEC approach or a deltoid split anterior lateral acromial approach. These are just kind of just so you guys have them. I'm not going to go over them or the intervals, but just so you know, the deltoPEC is more traditional and familiar, and there's benefits, pros and cons to having each one. So back to our case. We mentioned earlier, this is 58. She's an active. Prior to the injury, she was active. She's not, it wasn't more like she's not one of those elderly patients who wasn't really using their arms. So for her, we want to get her back at least to as much function as possible. She has significant displacement of the greater tuberosity. So normally for the greater tuberosity, we can only tolerate, in terms of operative fixation, 5 millimeters. If you guys recall from the case, hers was 1.2 centimeters, so 12 millimeters. And if you guys can see here, if we were to leave it in this position, if you start to abduct, the greater tuberosity is going to abut here, and you're going to have limited motion. You're going to have limited altered shoulder dynamics. So what would be the best treatment option for this? We see that the articular segment is intact. The vascularity seems to be intact based on the medial hinge here. From out of all the options here, we can either do non-op treatment, which we're not going to do for her. We talked about that. It's important to fix this fracture to help her get her shoulder mechanics back and become more functional. So for her, we would do ORIF, open reduction internal fixation. They use a locking plate. This is just to show you guys algorithm again. And this is the plate here they use. It's a locking plate. And she did great.
Camille, can you just touch on what you have to pay attention to when you're putting that plate in with your proximal screws?
So this is kind of like more of the advanced things, but a lot of times when you guys start doing surgeries on these, or even answering questions as residents, or maybe even upper level, you have to understand, you have to know all of the major complications with each of the main surgeries. So for the number one question or the concern that comes up for these, if you can imagine, these screws will cut out. And sometimes not having this calcar screw, which is one of the more important screws, because the bone here is usually the strongest. So for these, you can have several different complications after the surgery, but the number one that's usually tested is screw cutout. And if this articular segment was to fall into varus, you can imagine all these screws would be sticking out here.
Yeah, and when you're putting them in, you just have to make sure that you don't violate the articular surface. So
right. So once you put them in and you're satisfied with your length and you've assessed everything, before you leave the operating room and before you do anything, you can you take X-rays and you kind of circumferentially move the arm, so you can make sure that all the screws on all the views are intra-articular, so they're not violating the cartilage here, so you know they're not sticking into the joint. Because if they're sticking into the joint, you can imagine every time the patient moves their shoulder, they're going to be scratching the cartilage on the glenoid side and exacerbating any arthritic changes and accelerating any damage to the joint. And the whole purpose of doing all these surgeries we're trying to salvage the joint. We're trying to save the joint and have the patient maintain their native joint. Because if they ever needed it, we can do it down the line. So I just have a few quick questions on things that always come up, especially for medical students that during when you guys rotate as AIs or even on your in school. Some questions that might come up in the OR with attendings or residents. So which one of the following is not one of the 4 parts included in the NEAR classification? So we mentioned the 4 parts earlier to you. Which one of these was not one of the ones mentioned? Is it A, greater tuberosity, B, lesser tuberosity, B, bicipital groove, or D, the humeral shaft?
All righty. Another couple seconds. All right.
Nice. Okay, 90% got it right. So good job. How can you go back there? So we mentioned earlier, these are the 4 parts that are mentioned that for the NEAR classification system. It's the greater tuberosity, the articular surface, the lesser, and the shaft. The bicipital groove, which is between the greater and the lesser, is not one of the parts. So nice job for the majority. Question 2, what attaches to the lesser tuberosity? Is it A, the supraspinatus, B, infraspinatus, C, long head of the biceps, D, teres minor, or E, subscapularis?
Alrighty.
Nice job to 19 of you. Okay, and last question. So as we mentioned, the subscap attaches to the lesser, and the supraspinatus, and to the greater tuberosity, we have the other 3 parts of the rotator cuff: the supraspinatus, infraspinatus, and teres minor. And this diagram can show you guys here. This is a subscap attaching to the lesser here. Supraspinatus attaching to the greater here. We can't see, this is looking from the front, but the infraspinatus and teres minor are more posterior, and they're attaching also to the greater. And finally, we talked about the importance of one of these views, not only in terms of being able to see certain fractures, but also being able to help identify whether there is a dislocation. So what imaging view is shown below? Is it A, axillary, B, AP, C, true AP, D, scapular Y, or E, the Velpo?
Alrighty.
Nice. So this is the axillary view. I think if we look here, this is how we obtained that view. And we mentioned it helps us to identify if there's a dislocation. And then I alluded to that sometimes, especially in patients with fractures in the shoulder or proximal humerus fractures, like as this topic, it's kind of difficult to obtain this view. And the alternative is to get a Velpo view, which I will show you guys right before we finish today here. So thank you guys. If you have any, please, if you have any questions, let me know.
Hey, Camille, I think Jeremy just taught me how technology works, and so I got my microphone to work. Only one thing I'd really, I mean, one thing I want to add is that proximal humeruses are very easy to think that we treat all of them non-operatively, because a lot of them do get treated non-operatively, but they are really no different than fractures in any other part of the body, where their fractures can always be divided into two different categories: those that are low energy and those that are high energy.
Mm-hmm.
And so we see fractures in all different areas of the body that fall in this bimodal distribution, where you have little old ladies or frail old men who fall down and break the same anatomic location as, you know, a 30-year-old girl or 25-year-old guy who gets in a high-speed motorcycle crash or a car crash, and they break the same anatomic area. And the treatment is almost never the same. So it just so happens that when an older person falls over, of the basically four most common places for them to break are their hip, their wrist, their back, and their shoulder. And so we see a ton of proximal humerus fractures, and 90% of the time, like, we just treat it without surgery. We put it in a cuff and collar, and it just consolidates and heals, and they do fine. But that does not translate into proximal humerus fractures are treated non-operatively. And I think that algorithm that you went through is really nice. When you have younger people looking at the pattern of displacement, looking at how that pattern is going to cause deformation based on the forces and cause functional limitations. And that's where it gets very, very interesting, is in younger people who have these proximal humerus fractures.
One other thing to add is, in our non-operative treatment, we usually immobilize them, like Camille said, for a short period of time, and then we start range of motion exercises. And one good range of motion exercise that we start early on is something called pendulum swings. And so what that is I'll stand up and demonstrate it. Is, yeah, the patient lean forward, so their arms just hanging down straight, and you have them just do a pendulum motion, so just rotate out in a circular motion. And what that's doing is they're leaning forward and getting motion, but they're actually really elevating their arm up, but they're eliminating the force that it takes to go through gravity to bring their arm up in flexion or abduction, because they're bent over. And so they're getting the range of motion benefit without having to strain their muscles and counteract gravity. So that's something that we do early on with older patients, and also for any, early on with any type of shoulder surgery. We just got a question in the chat. So why is the greater tuberosity specifically focused on for a less forgiving amount of displacement? They assume that it's related to the number of rotator cuff muscles attachment / overall mobility. Camille, I think you touched on this briefly. If you want to,
if I can go back,
explain a little more.
So it's not because of the number of attachment and more so it's the location of the fragment and where this fragment is going to displace. So we said that the forming forces on the greater tuberosity are going to be your supraspinatus, your infraspinatus, your teres minor. They're going to abduct, externally rotate this fragment. And if you can see here where the acromion is, you can imagine as this piece displaces more and more up here, if it heals in that position, it's going to limit significantly your amount of abduction, even external rotation. If you can imagine this, if it heals in this position, you try to abduct, this piece of the bone will start to abut and hit this piece of the bone. So due to that, that's one of the main reasons that they tolerate a less amount of threshold for this fracture to be displayed
Camille just frees up for everybody.
Yeah.
Yeah.
Well, I think I kind of got a little distracted there. I wasn't quite sure where he was mid-sentence, but I think the overall gist of it is that the greater tuberosity is in a location that causes two problems. One, when it displaces, it displaces up into the subacromial space in between that acromion and the humeral head, which is a very limited space, and so it becomes a space-occupying lesion that then pinches on the musculature there. And number two is the supraspinatus and infraspinatus complex are excruciatingly important for functional mobility, because in order to initiate abduction of the shoulder, those first 15 degrees are done entirely by the supraspinatus before the deltoid tuberosity is brought into a position. Because if you remember, if my, can everybody see my hand? My knuckles would be the greater tuberosity, and if the line of pull of the supraspinatus is right here, it's at a 90-degree angle, so it has a high mechanical advantage, versus the deltoid is inserting down the length of the humerus, pulling in parallel fashion, so it can't abduct until the supraspinatus has pulled about 15 degrees. Then the deltoid has a mechanical advantage to abduct. So without the supraspinatus, you have a severe functional deficit. So that's why we prioritize that fragment.
Another question is it common to do a shoulder arthroscopy for surgically managed proximal humerus fractures to clean out any loose bodies, i.e. From trauma to the articular surface? Hey, you guys.
Sorry, say it again.
So is it common to do a shoulder arthroscopy for surgically managed proximal humerus fractures to clean out any loose bodies? I've never really seen that. Usually, if there's loose bodies from like fragments in the articular surface, if it's that comminuted, you're not going to do an ORIF. So in that case, you're going to be, usually in a delta pec approach, you're going to be opening up the joint and removing the the humeral head. So
Right.
at that point, you're going to be taking out any fragments that you see. So majority of the time, I would say no to that.
It could be common though, to go back later. Not common. It could be useful occasionally to go back later if a patient develops arthrofibrosis or a frozen shoulder, so-called adhesive capsulitis after a proximal humerus fracture, and you could do a arthroscopic lysis of adhesions or a capsular release in order to improve the patient's motion. That's sometimes done in the knee as well if a patient develops a very stiff knee, rather than just putting them under anesthesia and just cranking on their knee and tearing through scar tissue and risking fracturing the bone. If they're really stiff, you can go and just surgically debride and release some scar tissue with a shaver and then manipulate. And you can do the same thing in the shoulder. Is it common though? I mean, I've personally never seen it, but it certainly is a viable option if you had a stiff shoulder.
Yeah. And then another thing, just touch on, just because I'm thinking about it, is, as Camille mentioned, the deltopecker approach is your most common, I would say. That's when I've treated proximal humerus fractures, that's the only one I've used. That being said, I know some people only will do delta split. So one, I think it's surgeon preference, and then two, the type of fracture. But I think overall, the majority of the time, it's a delta pec approach.
Yeah, we had one not so long ago, I think 3 weeks ago. Dr. Riley at our institution did a deltoid split because of and it was, he did it strictly based on the fracture pattern. So if there's a certain specific fragment or a aspect of the fracture that you need to get to at a certain angle, then that might change your trajectory, and you might go through a deltoid split. I think the one that he did was a valgus impacted humeral head, and he needed to go in and lift it up more. And that was why he went that way.
Another question, Camille, if maybe you want to go back to your slide on hurdles, just understanding the medial hinge, and does hurdles help decide whether to do an arthroplasty or not? I can get you to that slide now because I'm sharing it. I mean, I can just mention that hurdles is, it's predictive of osteonecrosis of the head. So it's going to tell you if whatever type of if you do an ORF or if you treat it non-operatively, and there's these criteria, these predictors that are here listed on the screen, that's going to predict if you're going to get osteonecrosis of the head. I would say yes if you're worried about that happening due to the fracture pattern. If there's a disrupted medial hinge, which is usually one of the more important ones we look at, if you're worried about that, then that might sway your treatment option to doing an arthroplasty, because then you're going to be removing the humeral head, and then you don't have to worry if it dies or not, because there's no more humeral head. I don't know if you guys have anything.
No, I agree. I think this criteria. I think this criteria just kind of helps you, and these were the criteria that were identified to help predict humeral head ischemia. But it's not a black and white story. For example, if you have a 25-year-old who has or 20-year-old who has a proximal humerus fracture, who has a less than 8 millimeters of calcar or a disrupted medial hinge, you would still, in that situation, try to give him the chance to heal with ORIF, as opposed to somebody who's much older who has some of these factors predicting humeral head ischemia, where you might be more inclined to give him arthroplasty just because of his age. Basically, a lot of these surgeries, once you do one of them, you can't go back. So if you were to go directly to an arthroplasty on a young patient, you obviously can't go back and try to fix it because you already removed the fractured segment. But if you were to try to fix it, and then, because these are not 100% predictive, these are just some of the variables that have been shown to kind of be correlated with humeral head ischemia. And if you were to head and go fix it and the person heals, then you save that person having to kind of the more salvage procedure. But these are just some things to kind of keep in mind when you're examining and you're critically evaluating the x-rays of some things that you might expect for the patient in terms of developing AVN or not.
Anybody else have any other questions to add? Joe, you have anything to add in?
No, I think that's great.
Yeah. Alrighty. If there's no more questions, we'll end it for the night. Thanks for everybody for joining us. We're going to be doing this every other week for the foreseeable future. And if you guys have any requests, feel free to email us or DM us on the Instagram account. It's njms.orthopaedics. We'll be happy to do any lectures that you guys want to hear about. We're trying to pick up some more common things that are being seen and try to get through a lot of different specialties. So thanks again for joining us, and we'll be back on in 2 weeks, same time, 7 p.m. for standard time on Wednesday.
Awesome. It
should be soon. I'll touch base with Joe because we have it recorded. So if it wasn't already sent out, it'll be sent out within today or the next few days.
All right. Thanks, everybody. Have a good night.
Thanks, guys.
Thanks.
Thanks, Camille.